Assalamu alaikum. My name is Dr. Haris Jamil, and I'm here to present. Topic of my presentation is fundamentals of robotic urologic surgery. First of all, these are the parameters we are going to see. These parameters. First of all, pre-operative preparation, operating room setup, strategic placement of team and equipment, performing procedure, and physiologic consideration in adults, complication, training, and practicing robot-assisted laparoscopic surgery. And conclusion. First of all, introduction. Surgical robot is a computer-controlled device that can be programmed to aid the positioning and manipulation of surgical instruments. The modern history of robotic surgery begins with the programmable universal machine for assembly, Puma 560, a robot which is developed in 1978. In 1985, Dr. Sen Yu used the Puma 560 to hold a stereotactic frame for brain biopsies. In 1988, Sir John Wickham and Brand Davis of the Imperial College London used the system to perform TURP. Since the 1980s, surgical robots have been developed to address the limitation of laparoscopy, including two-dimensional visualization, incomplete articulation of instrument, and ergonomic limitations. The goal of robot-assisted laparoscopic surgery is to help surgeons improve patient care by converting procedures that would have been otherwise performed by laparotomy into minimally invasive procedures. Robot-assisted laparoscopic surgery has all of the advantages of minimally invasive surgery, including less post-operative pain, smaller and possibly more cosmetic appealing incisions, shorter hospital stay and shorter recovery time, and faster return to work. Now, these are the different types of robot we are going to discuss. Surgical robots can serve several functions, include passive. Passive means robot movements are set pre-operatively or act to guide the surgeon to a surgical target. Means it is directed pre-operatively to perform the surgery. Now, the types of passive robots are autonomous. Robot performs a sequence of movements which are programmed pre-operatively. This is another type of passive robot. Supervisory robots serve as a navigational aid or a precise positioning system to direct the surgeon to a lesion or other surgical target. Means the robot helps the surgeon to target the primary location and to aid the correct planes to help in the surgery. Now, active surgeon directs the robot intraoperatively to move the surgical instrument. Terms used to describe active robots include. This is the type of robot we are using. Means surgeon direct the robots per operatively to help in the surgery. Impulsive surgeons are using the robot as a tool, but deeply engaged in the operating field as if they were actually right at the operating field. Haptics. The lack of haptics is a limitation of robot-assisted surgery. The surgeon cannot actually feel the resistance of the tissue as the instrument meets or manipulates the tissue. This is a type of limitation. The surgeon on the console does not feel the tissue or feel the strength of the tissue. That's why this is a limitation, but not a contraindication of the surgery. The teleoperated or telerobotic, the robot is manipulated by input devices under the surgeon control room from the operating table. Telepresence surgery, the teleoperated telerobotic surgery in which robot surgeon is located outside the operating room in other country or another city and directed the surgery from a remote place. Telementoring, transmission of audio and visual information from a robot-assisted setup to a remote site, thereby allowing a surgeon to guide a novice through a procedure. Means this type is basically guiding the surgeon or technician from a remote place. Teleillustration for use in telementoring. A surgical mentor can draw on the operating surgeon's video display. Dual console system, an innovation in surgical training introduced in 2009, involving two consoles with the option to swap control of instruments and increase robot-assisted surgical exposure from one surgeon to two per procedure.
This thing is done worldwide on davinci robot, not on Versus at the moment. When we went for training to Istanbul, there were dual consoles over there. So it's just like a car. When you're learning car driving, the other person has got all the controls of the car as well. So if you're not doing properly, he will take over. So there's a primary and a secondary console, and the primary console has got all the powers to take over from the secondary console. So if the surgeon who's operating is doing some mistake or anything, then the primary surgeon takes over. So that is a very good modality for teaching and training robotic surgery. What we realized is that the learning curve of robotic surgery is easier than the laparoscopic, because if I ask anybody over here in this room to suture on a robot, they will eventually in 5 minutes. But if I ask them to suture on a laparoscopic model, it will take them hours, at least hours to suture. So the biggest advantage of robotic surgery is that the learning curve is a bit less than laparoscopic.
The one disadvantage that Dr. Haris Jamil pointed out about the robotics was the lack of tactile sensation. What do you think? What difficulty or what problems you can face if you don't have tactile sensation while doing surgery, as compared to open surgery or laparoscopy? What do you think? What could be the drawback or limitations when you don't have tactile sensation while doing surgery? Anyone?
In open surgery, when we cut a tissue, we can feel with fingers, is there any vessel? But in robotic, we do not feel.
That's one of the points. What else?
सर लाइक पार्शियल नेफ्रेक्टमी जब हम ओपन में करते हैं उसमें हम मैस को फील कर रहे होते हैं कि हम कहाँ से प्लेन बनाते हैं अपना कि हम कहाँ से जा सकते हैं, पर उसमें हम नहीं फील कर सकते तो हम यह नहीं पता लगा सकते, तो फिर हम सीटी स्कैन के लिए अकॉर्डिंग चलेंगे।
अरे साहब, इसको रोबोट ने कैसे रिप्लेस किया? आपके जो जैसे फॉर एग्जांपल हम जब सर्जरी करते हैं हम तो आदि हैं,
So
रोबोट ने किस तरह रिप्लेस किया है इसको, जो टेक्टाइल sensation है जिसके हम यूज
sir, we have technicians for this which help who help the surgeon to identify, or who have the tactile sensation, or who have laparoscopic instrument. But in partial nephrectomy, visual seeing the tumor and the extent of tumor is better display than in naked eye, because 3D vision, we identify the tumor extent, and if we are in a doubt that we remain the tumor, so we did ultrasound guided laparoscopic ultrasound, so we can identify the remaining tumor.
And this surgery, robotic surgery, is not completely autonomous. So this is a laparoscopic assisted surgery, robotic lap assisted surgery. That is why we get benefit from that. But I would like to update that the latest davinci robot, which is being made by Intuitive company, has given tactile feedback in robotic surgery as well. As the things are improving, science is taking its course, and recent advances are coming. So all these things, they're working on it, and we give a very good feedback that these things should be included or not included and all. So about the tactile feedback, it will also
in near future we are able to. Now, pre-operative preparation. First of all, patient selection. Prior surgeries and physical examination is the most important thing while selecting the patient. If a patient has had prior surgeries, then this is a relative contraindication, not absolute contraindication, because we recently operated multiple cases who had surgeries prior to. We had faced difficulty in dissection, but it is not contraindicated.
And
And-
another advantage we get is that the previous surgery was retroperitoneal,
Retroperitoneal.
and this surgery is being done transperitoneal. So we get a good access to the hilum. Once we get a good access to the hilum and we clip those vessels, then we can easily dissect out the kidney.
And physical examination is very important because we have to pay port placement. We have to consider the anatomy of the patient and physical examination, his tummy, his abdomen, scar marks, everything. Now, location and extent of all abdominal scars. First, if a patient has hysterectomy, this is not a contraindication while doing nephrectomy or partial nephrectomy because we are operating in upper part of the abdomen and it is trans-abdomen, so we are easily accessible to the retroperitoneal structure, kidney, or upper tract surgery. COPD is a relative contraindication, cardiac arrhythmias. Basically, the most experienced laparoscopic surgeon in the world are also experts at patient selection. Because if we prior take the decision how to operate and how to manipulate the things, we easily operate operatively and post-operatively manage the patient. And this is a team effort, and anesthetists, cardiologists all played a role in selecting the patient and manage post-operatively. And now the contraindication include uncorrectable coagulopathy, intestinal obstruction, suspected malignant ascites, generalized peritonitis, significant abdominal wall infection, excessive prior abdominal or pelvic surgery. If a patient underwent laparotomy or infective surgery, suspected perforated appendicitis, and this is a contraindication to the. But we tried these cases also. If a surgery occurred 10 years back, then we hopeful to we are able to perform the surgery in these patients also. Organomegaly, ascites, pregnancy second trimester, hernia, iliac or aortic aneurysm, ball preparation, morbid obesity. Morbid obesity, recently we operated a patient having morbid obesity. So this is not a absolute contraindication. Doctor?
प्रेगनेंसी सेकंड ट्राइमेस्टर में क्या
If pregnancy नहीं सर
फर्स्ट में कर सकते हैं
फर्स्ट में कर सकते हैं, लेकिन सर अपर ट्रैक रीनल सर्जरी, अपर ट्रैक सर्जरीज होती हैं तो उसमें कोई कॉन्ट्राइंडिकेशन नहीं
कर सकते हैं
जी।
थर्ड में भी कर सकते हैं
थर्ड में भी अवॉइड करते हैं बिकॉज लेप्रोस्कोपी गैस इन्फ्लेशन and metabolic things and respiratory problems, so we avoid.
And we have to assess in a tumor patient, we have to assess that what is more important, the tumor is more important or the pregnancy is more important. So because in a normal case, if the patient has got stone or any other problem, then you can give time. What we usually do is we ask the patient that if you're not having mild hydronephrosis, so you go with the pregnancy and we look after the hydronephrosis later. But it's quite different for a tumor because you cannot wait 9 months, 6 months for a tumor that it may metastasize. So in that case, this is an exception that you have to go for the tumor surgery first and then decide about the pregnant. We haven't done robotic, but we have done 2 cases of with open modality. So one we
In second
performed a
trimester.
radical nephrectomy, and in one we performed a partial nephrectomy. So we haven't gone for that. Patient was not couldn't be done with a robot. Otherwise, we could have tried to do it.
Because
So-
pneumoperitoneum is a very different thing, and we now operating room patient positioning. These are the different positions of the patient.
You just said that diaphragmatic hernia is in a contraindication for laparoscopic surgery.
Yes.
Is it really?
Relative contraindication.
So when I was in general surgery, I heard about laparoscopic fundoplication. This is kind of hernia.
So depending upon the patient and the condition and the extent of the hernia.
Whenever we are trying to define some sort of contraindication, then we have to choose our words wisely. It's being said that whatever can be performed by open technique can be performed with the laparoscopic or robotic surgery.
This is
I
this one?
totally agree
Oh.
with Dr. Naveed. The guidelines which Dr. Harris has shown, they are a bit old. And there are two things going on. There is one thing which is quite bookish, and there is one thing which is going on that you experiment and try something new. So I totally agree that can be done with the laparoscopic and robotic surgery.
I just want to add on one point that what Dr. Haris Jamil mentioned about the contraindication, or absolute or relative, about the diaphragmatic hernia. It's about when the bowel content they protrude into the chest cavity. Na? That's the diaphragmatic hernia. In these cases, there is respiratory compromise. So the logic behind avoiding the laparoscopy or robotic surgery in such cases is to further compromise the respiratory effort of the patient. But that's one of the reason the diaphragmatic hernia is one considered as one of the relative contraindication.
And just to add on to this information, in the coming year, that is 2025, we are planning to have one conference on robotic surgery, and there is a whole session which is just on hernia, and it is not only external hernia but it is also on internal hernia. So how to deal with hernia, and this idea of putting the whole session, 3 hour session on hernia, was actually proposed by somebody who is now the president of Robotic Society, International Robotic Society, and he happens to be a cardiothoracic surgeon. So the field is very, very much open now, and there are many things which, to my knowledge, there are certain terminologies which I have heard just right now, maybe 15, 20 days back. They were there in the wider arena of robotic surgery, but still not in this part of the world. Maybe we are late in just joining or hearing towards that kind of aspect, but it is still on.
Just like cardiac surgeries, bypass and everything. Now they are planning. I guess they have done one as well, and they are planning more. So all those things which were contraindicated previously, now they are just doing.
For instance, in cabbage, instead of having a graft from the venous vein, you can have internal memory vein for the same purpose. So you don't have to open up the chest. And this is done earlier by laparoscopy, and nowadays by cardiothoracic surgeon on robot. So
and even the thyroid surgeries, they are planning to do it they are placing the ports in the armpit and the chest, and that your neck can remain clear. So they do it inside that you have a scarless neck. So a lot of things which were contraindicated are now not contraindicated. So things are improving at a very fast pace.
मेरे ख्याल में ये कि since we are entering into this field, and we are entering into this field maybe कितने हुए 5 साल 6 साल
2017 से हमने
2017. So we must not keep our eyes and ears closed to anything. Everything which is contraindicated now is a relative contraindication maybe. So it might become an indication, or it has become an indication in some part of the world.
Now, the patient position, we use different position. Supine position, Trendelenburg position, lateral decubitus position for upper tract surgeries. So for pelvic surgeries, we use Trendelenburg position. Prophylaxis and other preparation, pneumatic compression stocking, heparin, Foley catheter, and NG tube. Now, these are the different positions we use for different procedures. First of all, supine position. This is the supine position, and this is for Trendelenburg position for robotic surgeries for pelvic organs like prostate and cystectomies. This is lateral decubitus position for upper tract surgeries. Trendelenburg position pose different difficulty in respiratory problems and cardiac problem, but we didn't see much more complications, except patient gets edema in the face, increase pulse pressure in the head, which pose difficulty in extubation and laryngeal edema post-operatively. Now, this is the instrument we use in theaters. Insufflation pressure can be continuously varied from 0 to 30, depending on the patient condition. If the anesthetist said lower down the patient, we manipulate the intra-abdominal pressure according to the situation. But ideal pressure is 12 to 15 mm per Hg. Total gas flow volume can be set to any value in the range 0 to 9.9 liters per mm. This is the suction tube can be used for blunt dissection, normal standing related for irrigation purpose. Sometimes heparinized saline is used to dissolve blood clots. Now, these are the complications related to position of patient include ocular injuries, leg compartment syndrome, laryngeal edema. Ocular injuries occurs in 1 to 3% of the patients include perioperative blindness, but these are very rare, because increased flow to the head poses these problems. Leg compartment syndrome include myoglobinuria and renal failure. This is also very rare. But these all complications related to the time of the surgery. If the duration of the surgery is greater than 4 hours, then these complications arise from after 4 hours. So the duration of the surgery, the position of the patient is very important.